Sometimes the difference between saving a life and destroying a career is a single heartbeat. And Dr. Sarah Mitchell was about to discover she could only choose one. The surgical lights of Operating Room 3 at Naval Medical Center San Diego cast everything in harsh white clarity, the kind of illumination that made mistakes impossible to hide. Sarah stood across from Dr. Gregory Hartman, the hospital's celebrated cardiothoracic surgeon, watching his hands work with the confident precision of someone who'd performed this procedure hundreds of times. If you want to hear more stories like this, subscribe to the channel right now. And tell me in the comments, where are you listening from tonight? Clamp. Hartman's voice carried the authority of 15 years at the top of his field. Suture. Steady pressure on that bleeder, Mitchell. Don't make me regret letting a third-year resident assist on my cases. Sarah applied pressure exactly as instructed, but her eyes kept drifting to the cardiac monitor. Something wasn't right. The EKG trace showed a pattern she'd seen before. Subtle irregularities in the QRS complex that most surgeons would dismiss as artifact or normal variation. But Sarah knew better. Dr. Hartman. She kept her voice measured, professional. I'm seeing what appears to be a bifascicular block on the monitor. The patient might have an undiagnosed conduction defect that could what, Dr. Mitchell? Hartman didn't look up from his work. 'Cause problems you're imagining based on 3 years of residency versus my 15 years of practice. Around the operating table, the surgical team shifted uncomfortably. The scrub nurse, a veteran named Linda Chen who'd seen decades of OR politics, met Sarah's eyes with a look that said, "Let it go." But Sarah couldn't let it go. Not when she recognized the pattern from her previous life, from surgeries performed in very different circumstances. Sir, if the patient has a high-grade AV block, the anesthesia and surgical stress could precipitate complete heart block post-operatively. We should run additional cardiac studies before what? Hartman's hands stopped moving. He looked up, and Sarah saw the flash of anger in his eyes. Before you, a resident who's barely qualified to hold retractors, question my surgical judgment in my operating room. The temperature in the OR seemed to drop 10 degrees. I'm not questioning your judgment, Dr. Hartman. I'm identifying a potential complication that you're inventing out of resident anxiety and an inflated sense of your own diagnostic capabilities. Hartman's voice rose enough that the circulating nurse by the door flinched. This patient has been thoroughly evaluated. His cardiac function is normal. What you're seeing is benign variation, not pathology. Sarah glanced at the monitor again. The irregularities were becoming more pronounced, not less. Her training screamed warnings that 15 years of civilian surgery apparently couldn't hear. Dr. Hartman, with respect, those waveforms indicate that you need to learn when to stay in your lane, Dr. Mitchell. Hartman turned to the attending anesthesiologist. Dr. Park, please note in the record that Dr. Mitchell is demonstrating overeager interference in a routine procedure. Sarah felt her face flush. Around her, the surgical team kept their eyes down, nobody willing to contradict the hospital's star surgeon. Sir, I'm only trying to... You're trying to build a reputation by manufacturing drama where none exists. Hartman's tone turned ice cold. Nurse Chen, please escort Dr. Mitchell from my operating room. Immediately. The words landed like a physical blow. In surgical hierarchy, being removed from an OR was professional humiliation, a mark that could follow a resident through their entire career. Dr. Hartman, please, if you'd just look at... Now, Dr. Mitchell. Hartman returned to his surgery, dismissing her existence with practiced ease. And I'll be filing a formal complaint with the chief of surgery regarding your fitness for continued surgical training. Perhaps internal medicine would suit your talents better. Sarah stood frozen for a heartbeat, staring at the monitor that continued displaying patterns nobody else seemed to see. Then Nurse Chen touched her elbow gently, sympathy evident in her weathered face. Come on, honey, don't make this worse. Sarah stripped off her gloves and walked out of OR 3, with her head high and her career crumbling. Behind her, she heard Hartman's voice resume its confident rhythm, teaching the remaining residents as if nothing had happened. But as the OR doors closed, Sarah caught Nurse Chen's expression and saw something there that looked like recognition mixed with regret. The look of someone who'd watched brilliant doctors get destroyed by arrogant superiors too many times to count. Sarah was filling out incident reports in the residence lounge when the code blue alarm shattered the afternoon quiet. Code blue or 3. Code blue or 3. All available personnel respond immediately. Her pen stopped mid-word. Or 3. Hartman's surgery. The patient she'd been expelled for trying to warn them about. Sarah's feet moved before conscious thought engaged, carrying her toward the surgical wing, even as hospital protocol said she had no business being there. She reached the observation deck above OR 3, just as controlled procedure collapsed into controlled chaos. The patient, Mr. Robert Chang, 47 years old, routine mitral valve repair, lay on the table in full cardiac arrest. Monitors screaming flatline. Hartman performing chest compressions with the mechanical efficiency of someone who'd done this too many times. The anesthesiologist pushing medications through IV lines with practiced urgency. Epi, 1 milligram. Charging paddles to 200 joules. Dr. Park's voice carried the calm of emergency protocols overriding panic. Everyone clear. The defibrillator discharged. Chang's body arched. The monitor showed brief organized rhythm, then deteriorated back into ventricular fibrillation. Again. 300 joules. Sarah pressed against the observation glass, watching the scene unfold with the sick certainty of someone who'd predicted exactly this outcome. Complete heart block. The conduction defect she'd identified had progressed during surgery, and now Chang's heart couldn't maintain organized electrical activity. He's not responding. One of the residents, a second-year named Jason Liu, had fear creeping into his voice. Dr. Hartman? His rhythm isn't stabilizing. I can see that, Dr. Liu. Hartman's composure showed cracks. Amiodarone, 300 milligrams. Someone check the pacing wires. Make sure they're properly positioned. 30 minutes. They worked on Robert Chang for 30 minutes, cycling through every protocol in the advanced cardiac life support algorithms. Medications, defibrillation, external pacing. The mechanical ballet of doctors refusing to let death win. Finally, impossibly, Chang's heart found a rhythm. Weak, irregular, requiring chemical and electrical support to maintain, but alive. Stabilize him for transfer to ICU. Hartman stripped off his gloves, surgical mask unable to hide the exhaustion in his eyes. Someone notify the family. Complications during surgery. But patient is alive and we're monitoring closely. Sarah turned away from the observation window before anyone could see her there. But as she walked down the corridor, she passed Nurse Linda Chen emerging from OR 3, still in surgical scrubs, expression tight with something between anger and vindication. You were right, Chen said quietly, voice pitched so only Sarah could hear. Complete AV block, exactly like you warned. I documented your concerns in the surgical record before Hartman expelled you. She paused. For what it's worth, Doctor. Mitchell, you tried to save that man. Hartman's ego nearly killed him. 2 hours later, Sarah sat across from Dr. Richard Moss, chief of surgery, in his office that smelled like old books and resignation. Dr. Mitchell, I've reviewed the incident report from this morning's surgery. Moss's voice carried the weight of administrative decisions that pleased nobody. Dr. Hartman has filed a formal complaint stating that you demonstrated poor judgment, inappropriate interference, and unsuitable temperament for surgical training. The patient coded exactly as I predicted, sir. Sarah kept her voice level despite the fury building in her chest. Complete heart block from an undiagnosed conduction defect visible on the intraoperative EKG. If Dr. Hartman had listened, perhaps the outcome would have been different. Moss removed his glasses, rubbing tired eyes. But speculation doesn't change the fact that you questioned the judgment of a senior attending surgeon in his operating room. That's a violation of surgical hierarchy and protocol. Protocol that nearly killed a patient. A patient who is currently alive in ICU. Thanks to Dr. Hartman's successful resuscitation. Moss replaced his glasses. I'm suspending you from surgical duties pending formal review. 2 weeks administrative leave while we investigate the incident. The words hit like a physical blow. Sir, with respect, you're punishing me for being right? I'm following hospital protocol regarding residents who demonstrate inability to work within established surgical hierarchies. Moss's tone suggested he hated every word he was speaking. Dr. Hartman has 15 years of exemplary service. You have 3 years of residency. Who do you think administration will support? Sarah left Moss's office with her ID badge deactivated and her surgical privileges suspended. In the hallway, she nearly collided with Dr. Marcus Chen, fellow third-year resident, and one of the few people at Naval Medical Center she considered a genuine friend. "Sarah, I heard." Marcus's expression mixed sympathy with frustration. "This is bullshit. Everyone in that OR knew you were right. But Hartman has too much power here. Too many successful surgeries under his belt. He'll sacrifice your career to protect his ego. So I'm supposed to just accept this?" Sarah's voice cracked slightly. "Accept that speaking up about patient safety destroys my future?" "I don't know." Marcus gripped her shoulder. "But I know you tried to do the right thing. That has to count for something." That night, Sarah sat alone in her apartment, staring at a locked case in the back of her closet. Inside were items from a life she'd deliberately left behind. Uniforms, medals, photographs of people she'd served with in places that officially didn't exist. She'd walked away from that world to become a surgeon, believing civilian medicine would let her save lives without carrying weapons or watching friends die under fire. But now she wondered if she'd traded one impossible battle for another, where egos killed as efficiently as bullets, and truth was the first casualty of hospital politics. Sarah's suspension had lasted exactly 4 days when her phone rang at 3:17 a.m. She jolted awake, fumbling for the device on her nightstand, expecting maybe Marcus with news about Robert Chang's recovery, or possibly another apology call from Nurse Chen, who'd been trying to rally support for Sarah's reinstatement. Instead, the screen showed, "Naval Medical Center, emergency. Dr. Mitchell." The voice was clipped, military, no introduction. "This is hospital security. Naval Medical Center San Diego is entering Code Black lockdown status. All personnel are ordered to shelter in place. Do not attempt to access the facility." "I'm suspended. Why are you calling?" The line went dead. Sarah stared at her phone, instincts from her previous life suddenly screaming warnings. Code Black wasn't a standard hospital emergency protocol. It was military classification, the kind of lockdown that happened when national security took precedence over civilian operations. She pulled up the local news. Nothing. Social media showed confused posts from hospital staff who lived on base, talking about armed military police establishing perimeters, roads blocked, nobody allowed in or out. Whatever was happening at Naval Medical Center wasn't making the news because someone with serious authority wanted it invisible. At 3:47 a.m., her phone rang again. Different number. Same clipped military tone. "Dr. Mitchell, this is Lieutenant Commander Jake Riker, Naval Special Warfare Command. Are you at your current residence?" Sarah's blood went cold. Naval Special Warfare meant SEALs, and SEALs calling a suspended surgical resident meant something had gone catastrophically wrong. "Yes. What's happening?" "Stand by for further instructions. Do not leave your location." The line went dead again, leaving Sarah sitting in darkness with questions multiplying faster than answers. Inside Naval Medical Center, chaos wore the mask of military precision. Armed Navy SEALs in full tactical gear had established security perimeters on every floor. Military police cleared corridors, ordering confused night shift nurses and residents into secured holding areas. The hospital's administrative staff received terse instructions. No questions, no phone calls, complete information blackout. "Dr. Gregory Hartman had been in his on-call quarters when security woke him with orders that overrode every hospital protocol he knew. "Dr. Hartman, you're needed in Trauma Bay 1 immediately. Classified patient, catastrophic injuries, your expertise is required." Now he stood in the trauma bay, surrounded by SEAL team members who watched his every movement with eyes that had seen too much death to tolerate incompetence. The patient on the gurney barely qualified as alive. No identification, no medical history, no name. The chart simply read, Patient X. Male, approximately 35 years old, muscular build suggesting military special operations. Injuries that told a story of violence Hartman couldn't begin to imagine. Penetrating chest trauma from what looked like high-velocity fragmentation. Embedded shrapnel visible on preliminary scans. Internal bleeding that had already required 6 units of blood just to maintain blood pressure. What happened to him? Hartman directed the question to the SEAL commander standing near the door, a man whose nameplate read Riker, and whose expression suggested he'd kill anyone who asked too many questions. Classified. Riker's voice carried the weight of orders backed by national security. Your job is to keep him alive. Nothing else matters. Hartman pulled up the CT scans, and his stomach dropped. The shrapnel, multiple fragments of what looked like ordnance rather than accidental debris, was embedded directly in cardiac tissue. One piece sat against the posterior wall of the left ventricle, another fragment pressed dangerously close to the coronary arteries. This is... Hartman struggled for words that wouldn't sound like defeat. This is beyond survivable parameters. The extraction would require the best cardiothoracic surgeon in this facility. Riker stepped closer, voice dropping to dangerous quiet. Which our intelligence says is you, Dr. Hartman. So I'm going to say this once. This operator doesn't die. Whatever it takes, whatever resources you need, you find a way. Around the trauma bay, hospital staff worked with the tense efficiency of people aware they were operating under scrutiny that went far beyond normal medical oversight. And in the hallways outside, armed SEALs stood guard over a patient whose existence was classified and whose survival apparently mattered more than any protocol Hartman had ever known. 4 miles away, Sarah Mitchell sat in her apartment staring at her phone and the locked case in her closet, wondering why Naval Special Warfare was calling a suspended resident in the middle of the night, and knowing, with absolute certainty, that her carefully separated lives were about to collide in ways she'd spent years trying to prevent. Dr. Gregory Hartman had performed over 3,000 cardiac surgeries in his 15-year career, but he'd never stared at scans that looked like a death sentence written in shrapnel and blood. Patient X's CT images filled the surgical planning room's display screens, three-dimensional reconstructions showing fragments of what appeared to be explosive ordnance embedded in cardiac tissue with surgical precision that would have been impressive if it weren't catastrophic. The largest piece sat against the posterior wall of the left ventricle, mere millimeters from the coronary arteries. One wrong move during extraction would cause hemorrhage that no surgeon could control. This is beyond survivable parameters. Hartman's voice carried the weight of mathematics that didn't care about military necessity. The shrapnel placement makes standard extraction impossible. Any approach risks immediate exsanguination. Lieutenant Commander Jake Riker stood across the table, arms crossed, expression carved from stone. Behind him, 3 members of Patient X's SEAL team watched with the particular intensity of men who'd carried their brother out of a firefight and refused to let him die in a hospital. Dr. Hartman, I need you to understand something. Riker's voice dropped to the register men used when delivering ultimatums. This operator has information that makes his survival a matter of national security. He doesn't die on this table. You find a way. I'm a surgeon, not a miracle worker. Hartman gestured at the scans with frustration bleeding through his professional composure. The physics of this injury don't allow for... Then change the physics. Riker leaned forward. You're the best cardiothoracic surgeon at this facility. That's why we're here. That's why this hospital is under lockdown. So either you find an approach that works, or we find a surgeon who will. The threat hung in the air like surgical smoke. Hartman turned back to the scans, pulling in his assembled surgical team. The best residents and nurses Naval Medical Center could offer at 4 a.m. Dr. Marcus Chen stood among them, exhaustion evident in his eyes from being yanked out of sleep for an emergency that nobody would explain. We need to approach this systematically. Hartman traced his finger along the scan. Standard posterior approach puts us too close to the coronary arteries. Anterior access requires going through too much healthy tissue. Lateral approach... He stopped, calculating angles that refused to add up to survival. What about a staged extraction? Dr. Park, the senior anesthesiologist, suggested. Remove the smaller fragments first, stabilize, then attempt the larger piece in a second surgery. Patient won't survive a second surgery. Hartman's tone carried the weight of experience. Blood loss alone would be... He stopped mid-sentence, realizing he was calculating acceptable losses for a patient whose commanding officer had just made clear losses weren't acceptable. For 20 minutes, they debated approaches. Each option carried survival odds that made Hartman's chest tighten with the kind of fear he hadn't felt since his first solo surgery as a resident. 10% chance of success if they attempted immediate extraction. 15% if they tried staged removal. 20% if they used cardiopulmonary bypass. But that carried its own complications with a patient already hemorrhaging. Dr. Hartman, a junior resident, second year named Amanda Rodriguez, spoke up hesitantly. I remember reading a paper about unconventional cardiac shrapnel removal, posterior access using a modified thoracotomy approach that minimizes vascular disruption. The author was... Where was this published? Hartman seized on anything that might improve the impossible odds. Journal of Military Medicine, about 3 years ago. The technique was developed for battlefield extractions where standard approaches weren't available. Rodriguez pulled up her tablet, searching. The author was Dr. Sarah Mitchell. The room went absolutely silent. Hartman's jaw tightened until muscles stood out like cables. The resident I just suspended for insubordination? You want me to use techniques from someone who can't follow basic surgical hierarchy? Sir, the paper described successful extractions in 6 cases with similar shrapnel placement. Rodriguez's voice carried the careful tone of someone walking through a minefield. Survival rate was 73% using her modified approach. Absolutely not. Hartman turned back to the scans with finality. We'll use standard protocols adapted for the injury complexity. I don't need experimental techniques from a resident who doesn't understand her limitations. But even as he spoke, doubt crept into his voice. Because the numbers didn't lie, and 10% survival odds meant patient X would almost certainly die under his hands. Across the room, Lieutenant Commander Riker pulled out his phone, expression shifting from frustration to calculation, as he made a decision that would change everything. Lieutenant Commander Jake Riker stood in the surgical planning room, watching Dr. Hartman deliberate over approaches that all led to the same mathematical conclusion. Patient X would probably die under standard surgical protocols. Riker had spent 12 years leading SEAL teams through impossible missions where failure meant body bags and presidential briefings nobody wanted to give. He'd learned to recognize when expertise hit its limits, and when arrogance prevented people from asking for help they desperately needed. Hartman was drowning in both. While the surgical team debated angles and survival percentages, Riker pulled out his secure tablet and accessed Patient X's classified medical file, the complete record that hospital staff weren't cleared to see. He scrolled through mission history, previous injuries, medical evacuations from combat zones, and there, buried in an after-action report from 2018, Kabul Province, Afghanistan, he found exactly what he'd suspected when that resident mentioned Sarah Mitchell's name. Medical intervention performed by Navy Combat Medic Lieutenant Sarah Mitchell, embedded with SEAL Team 3. Successful cardiac shrapnel extraction under fire using modified posterior approach. Operator survived with full function restored. Riker read the report twice, memory flooding back to briefings he'd attended about unconventional medical techniques being developed by Special Operations Corpsmen. Mitchell's name had come up repeatedly. The combat medic who'd saved lives using approaches that made traditional military surgeons uncomfortable, but produced results that couldn't be argued with. And now she was here, at this hospital. Suspended by the same surgeon who was about to let patient X die because his ego couldn't accept help from a resident. Riker stepped out of the planning room and found Chief of Surgery Dr. Richard Moss in his office, looking exhausted and overwhelmed by a situation spiraling beyond his control. Dr. Moss, I need Dr. Sarah Mitchell brought to this hospital immediately. Moss looked up with confusion, that quickly shifted to defensiveness. Commander, Dr. Mitchell is currently suspended pending disciplinary review. She's not authorized to practice at this facility. I don't care about your internal politics. Riker's voice dropped to the register that made junior officers stand at attention. Patient X's survival is a matter of national security. Dr. Mitchell has successfully performed the exact procedure this patient requires. She will be in that operating room. Commander, with respect, bringing in a suspended resident undermines Dr. Hartman's authority and violates every hospital protocol. Dr. Moss. Riker leaned forward until his presence filled the small office. Let me be absolutely clear. Your hospital protocols are irrelevant compared to national security interests. Dr. Mitchell will be reinstated immediately and given full access to this case. That's not a request. The color drained from Moss's face. I'll need to consult with administration. You'll make one phone call. To Dr. Mitchell. Right now. Riker slid a phone across the desk. Tell her she's being reinstated for a classified surgical emergency, and she needs to be here within 30 minutes. Moss stared at the phone like it was a loaded weapon, then slowly picked it up. Back in the surgical planning room, Dr. Hartman had assembled his approach, a combination of standard techniques adapted for impossible circumstances. 10% survival odds dressed up in medical terminology that couldn't hide the fundamental problem. He was guessing. Dr. Hartman. Riker's voice cut through the planning session. Dr. Sarah Mitchell is being brought in to consult on this case. The room went absolutely silent. Hartman turned slowly, expression cycling through shock, anger, and disbelief. The resident I suspended? You're bringing her into my operating room? I'm bringing in the surgeon who's successfully performed this exact extraction under combat conditions. Riker's tone left no room for argument. Your hospital suspended her for being right about a patient complication. I'm reinstating her because patient X's survival requires expertise you don't possess. This is my hospital, my surgical team, my authority. Was your authority. Riker stepped closer, voice dropping to dangerous quiet. As of this moment, patient X's care falls under military jurisdiction. Dr. Mitchell will have operational authority in that OR. You can assist her, or you can step aside. Choose. Hartman's face flushed red. I will not be subordinated to a resident in my own. Then you're dismissed from this case. Riker gestured toward the door. I'll find another surgeon who's more interested in saving lives than protecting ego. The surgical team watched the confrontation with visible discomfort. Residents who'd never seen their attending challenged. Nurses who'd witnessed Hartman's authority go unquestioned for years. Finally, through clenched teeth, Hartman spoke. Fine, but when this suspended resident fails, the consequences fall on you. If she fails, Riker replied calmly, we'll all have bigger problems than hospital politics. At 4:47 a.m., Sarah Mitchell's phone rang with a number she recognized as Naval Medical Center Administration. Dr. Mitchell, this is Dr. Moss. You're being reinstated immediately for a classified surgical emergency. Report to the hospital within 30 minutes. Sarah stood in her apartment, still holding the locked case from her closet, and realized the past she'd tried to leave behind had just reached out and dragged her back into a world where lives depended on skills she'd spent years trying to forget. Sarah Mitchell drove through the pre-dawn darkness toward Naval Medical Center, with memories she'd spent 3 years trying to bury flooding back with every mile. The hospital appeared ahead, transformed. Armed sentries at every entrance. Military police vehicles creating security perimeters. Black helicopters sitting silent on the helipad like predatory birds. This wasn't a medical facility anymore. It was a fortress protecting something that officially didn't exist. She showed her ID at the checkpoint. The guard scanned it, nodded, and waved her through without the questions that should have accompanied a suspended resident being summoned at 5 a.m. Inside, the corridors felt wrong. Too quiet. Too controlled. The kind of operational silence Sarah recognized from deployments where mistakes got measured in body counts instead of malpractice suits. A SEAL in full tactical gear met her at the surgical wing entrance. No greeting, just a gesture to follow. They walked past observation rooms where more SEALs stood guard, past equipment that looked too sophisticated for standard hospital operations, toward a private briefing room where Lieutenant Commander Jake Riker waited. Sarah stopped in the doorway, recognition hitting like a physical blow. Lieutenant Mitchell. Riker's voice carried warmth that his military bearing couldn't quite hide. Good to see you again. Commander Riker. Sarah's response came automatic, muscle memory from a life she'd deliberately left behind. Then she caught herself. I'm not Lieutenant Mitchell anymore. Just Dr. Mitchell. Civilian. Suspended civilian, actually. Not suspended as of 30 minutes ago. Riker gestured to a chair. And you're not just anything, Sarah. You're one of the best combat surgeons I've ever worked with, which is why you're here. Sarah sat slowly, feeling the weight of recognition she'd avoided for years. How did you know I was at this hospital? I didn't. Not until your name came up during surgical planning for a patient whose survival requires expertise most civilian surgeons don't possess. Riker pulled up a tablet, showing classified medical files. You remember Kabul, 2018? Forward Operating Base Echo? The memories crashed through Sarah's carefully maintained barriers. Desert heat, mortar impacts. A SEAL operator on a field surgical table with shrapnel embedded in his chest, while enemy fire got closer by the minute. I remember. Her voice came out quieter than intended. Petty Officer First Class David Chen. Blast injury from an IED. Shrapnel lodged against his posterior cardiac wall. Exactly like 6 other operators you treated during your 2 tours. Riker's expression shifted to something between respect and desperation. You extracted that ordnance under fire using techniques that made Navy surgeons back at Bethesda uncomfortable. But Chen survived with full cardiac function. You got a Silver Star for that operation. I got lucky. Sarah deflected. Chen was strong. The shrapnel placement could have been worse. Sarah, stop. Riker's tone sharpened. You saved an entire SEAL team that day. Not just Chen. All 8 operators who'd been in that blast zone. You performed battlefield surgery for 11 hours while our position was being overrun, refused evacuation until every patient was stable. That's not luck. That's skill that this hospital desperately needs right now. He swiped to new images. CT scans showing injuries that made Sarah's chest tighten with professional recognition. Patient X. One of ours, mission classified. Shrapnel embedded in cardiac tissue. Posterior wall of the left ventricle, pressing against coronary vessels. Your attending surgeon, Dr. Hartman, is struggling with approach angles that won't work. Riker met her eyes. The injury pattern is identical to what you treated in Kabul. You're the only surgeon I know who successfully extracted ordnance from this exact position. Sarah studied the scans, and her training took over. The real training, earned in forward operating bases where theory met reality and patients died if you hesitated. She saw immediately what Hartman had missed. The angle of approach that utilized natural cardiac movement instead of fighting against it. The timing window between heartbeats where extraction could happen with minimal bleeding. This requires battlefield technique. Sarah's voice shifted, becoming colder, more clinical. Procedures that aren't in any civilian surgical textbook. Approaches that medical boards would call reckless improvisation. Approaches that have a 73% survival rate according to your published research. Riker leaned forward. Patient X doesn't survive standard protocols. He needs what you learned under fire. He needs the surgeon you were before you decided to hide behind a civilian residency. The words hit harder than Sarah expected, because they were true. She'd left special operations believing civilian medicine would let her save lives without the weight of combat, without carrying weapons, without watching brothers in arms die despite her best efforts. But she'd never stopped being the surgeon who learned to work miracles when failure meant flag-draped coffins. Dr. Hartman will fight this, Sarah said quietly. He'll see it as undermining his authority. Dr. Hartman's authority is irrelevant. Riker stood. As of this moment, Patient X's care falls under military operational jurisdiction. You have full surgical authority. Welcome back, Lieutenant Mitchell. Sarah stood as well, feeling the civilian identity she'd carefully constructed cracking under the weight of who she'd actually always been. The OR prep room felt smaller than it should have, like walls were closing in on a confrontation that had been building since the moment Sarah walked back into Naval Medical Center. Dr. Gregory Hartman stood near the surgical sink, already in scrubs, arms crossed with the rigid posture of someone whose authority had been publicly undermined. His surgical team lingered nearby, residents and nurses who'd witnessed the entire chain of events that led to this impossible moment. Sarah entered the prep room, and the temperature dropped 10 degrees. Dr. Mitchell. Hartman's voice carried barely controlled rage. You were suspended 4 days ago for insubordination and poor judgment. You have no authority in this hospital, let alone my operating room. Sarah met his eyes with the calm she'd learned under mortar fire, the kind of steady that came from performing surgery while bullets impacted nearby walls. Lieutenant Commander Riker requested me specifically for this case. If you have concerns, take them up with him. I'm taking them up with you. Hartman stepped closer. Invasion of personal space meant to intimidate. Why would a SEAL commander request a suspended resident for a case requiring the highest level of cardiothoracic expertise? Before Sarah could respond, Dr. Marcus Chen spoke up from near the equipment cart. He'd been silent since Sarah's arrival, but recognition had been building in his expression. The particular awareness of someone who'd served as a Navy physician and knew what combat medicine looked like. Oh my God. Marcus's voice carried shock mixed with understanding. You were military, special operations medical. He turned to Hartman. Dr. Mitchell wasn't just a combat medic. She was embedded with SEAL teams. That's why Commander Riker knows her. The room went absolutely silent, except for the hum of sterilization equipment. Hartman's expression cycled through disbelief, anger, and something that looked like threatened ego. A combat medic playing surgeon? This patient requires a specialist, not battlefield improvisation performed by someone who learned medicine in tents. The dismissal in his voice, the casual reduction of Sarah's experience to something less than legitimate surgery, finally broke through her professional composure. This patient requires someone who's extracted shrapnel from cardiac tissue while under enemy fire. Sarah's response came quiet but steel hard, each word landing with precision. Someone who's performed this exact procedure 6 times with a 73% survival rate. Someone who didn't have the luxury of saying survival odds are too low and walking away. She stepped closer until they stood eye to eye. So let me ask you, Dr. Hartman, which one of us has actually saved a patient with this specific injury pattern? Which one of us has operated while mortars impacted 50 meters away? Which one of us learned to work miracles because the alternative was body bags? Hartman's face flushed red. Your publication. Those techniques are reckless, unproven by peer review, dangerous shortcuts that might work once or twice but don't represent sound surgical practice. Those techniques saved lives when sound surgical practice would have meant flag-draped coffins. Sarah's voice never rose, but the intensity made residents step back. And right now, patient X needs those techniques, or he dies on your table using approaches that are failing before you even start. This is my hospital. This is a military operation. Lieutenant Commander Riker's voice cut through the confrontation as he entered the prep room. Dr. Mitchell has operational authority for patient X's surgery. Dr. Hartman, you can assist or you can step aside, but you will not obstruct care that this operator requires. Hartman stared between Riker and Sarah, realizing he'd lost control of a situation that should have been his domain. When this fails, then I'll answer for it. Sarah held his gaze. But it won't fail. Not if everyone in that OR follows my lead and stops pretending civilian protocols work for combat injuries. The surgical team watched the standoff with visible tension, residents caught between attending authority and military jurisdiction, nurses who'd seen Sarah expelled now witnessing her return with power that superseded hospital hierarchy. Finally, through clenched teeth, Hartman spoke. Fine. But this is your responsibility, Dr. Mitchell. Your techniques, your outcome, your consequences. Understood. Sarah turned to scrub, feeling the weight of lives depending on skills she'd tried to leave behind, settling back onto her shoulders like armor she'd never quite removed. And as she prepared for surgery, she knew the next few hours would either vindicate everything she'd learned under fire, or prove Hartman right in ways that would haunt her forever. Operating room 3 had never felt this tense. Patient X lay on the table, sedated and draped, his chest prepped for an incision that would either save his life or confirm Dr. Hartman's dire predictions. The surgical team assembled in positions they'd held 100 times before, but the dynamics had shifted in ways that made everyone uncomfortable. Sarah stood near the instrument tray, technically lead surgeon, but aware that Hartman's 15 years of authority wouldn't surrender easily. In the observation deck above, Lieutenant Commander Riker watched with the particular intensity of someone whose brother-in-arms lay on that table. Scalpel. Hartman's voice carried the practiced authority of someone reclaiming control through procedure. He made the initial incision with precise movements, opening the chest cavity with textbook technique. Sarah observed silently, watching him work toward an anterior approach that would access the shrapnel through healthy cardiac tissue. Standard protocol, safe and methodical, and completely wrong for this injury. Retractor. More exposure on the left ventricle. Hartman positioned instruments with confidence that didn't match the deteriorating situation. Sarah watched patient X's vitals. Blood pressure holding steady at 95/60. Cardiac output acceptable but not optimal. The numbers told a story Hartman wasn't reading. This patient's body was already compensating for damage that standard approach would aggravate. Dr. Hartman, Sarah kept her voice measured, professional. That approach puts you too close to the coronary vessels. The shrapnel position requires posterior access to minimize vascular disruption. Your opinion is noted, Dr. Mitchell. Hartman didn't look up from his work. I'm using proven techniques, not battlefield improvisation. Sarah bit back frustration and waited, knowing the mathematics would prove her right faster than argument. She gave Hartman 10 minutes. 10 minutes of careful dissection that brought him closer to the embedded shrapnel, while patient X's vitals started their inevitable decline. Blood pressure dropping. 88/55. Cardiac output falling as Hartman's approach compressed tissue that couldn't tolerate additional stress. Dr. Hartman, with respect, that approach will cause hemorrhage. Sarah stepped closer to the table. I have an alternative that... Your alternative is unnecessary. Hartman's tone sharpened with defensive ego. I've performed 3,000 cardiac surgeries. I know what I'm doing. But the monitors disagreed. Blood pressure continuing to drop. 82/50 now. Heart rate climbing as patient X's body tried to compensate for inadequate cardiac output. Sir, the patient is decompensating. Dr. Park, the anesthesiologist, voice carried warning. Blood pressure unstable. I'm increasing pressors. I see that. Hartman's hands moved faster, trying to reach the shrapnel before the patient crashed entirely. Just maintain him stable while I complete the approach. Sarah watched the vitals cross into critical territory. 75/45. Cardiac output dropping below sustainable levels. In 30 seconds, maybe less, patient X would code on the table, and Hartman's pride would kill him as efficiently as enemy fire. Dr. Hartman, stop. Sarah's voice cut through the OR with command authority that made residents look up. You're going to cause catastrophic bleeding if you continue. I will not be questioned in my own operating room. Lieutenant Commander Riker's voice came through the observation deck intercom, cold and final. Dr. Hartman, step back from the table. Dr. Mitchell has operational authority. That's an order. The OR went absolutely silent except for monitors measuring a life hanging in the balance. Hartman stood frozen, scalpel in hand, ego warring with military reality. Finally, slowly, he stepped back from the table with movements that screamed humiliation. Sarah moved into lead position without hesitation, her hands finding instruments with muscle memory from surgeries performed under very different circumstances. The entire team watched as she transformed. Not dismissed resident anymore, not civilian surgeon learning protocols, but combat medic who'd learned to save lives when failure meant brothers in arms dying under her hands. Changing approach to posterior access. Sarah's voice carried the calm of someone who'd operated while mortars impacted nearby. This will require timing the extraction between cardiac cycles. Everyone needs to be ready to move fast when I call for instruments. And as her hands began the delicate work of approaching the shrapnel from an angle Hartman had dismissed as too risky, the surgical team realized they were witnessing something most civilian hospitals never saw. Battlefield medicine brought into an operating room where survival mattered more than protocols. Sarah's hands moved with the precision of someone who'd learned surgery where mistakes couldn't be corrected. Only survived, or mourned. The shrapnel is lodged against the posterior cardiac wall, pressing directly on the left coronary artery. Her voice carried the clinical calm of battlefield triage. Standard extraction would cause immediate hemorrhage. We need to work with the cardiac cycle, not against it. She adjusted her position, studying the embedded ordnance through the surgical field she'd opened, using an approach Hartman had never seen attempted. Posterior access through a modified thoracotomy that minimized tissue trauma while maximizing visibility of the injury. Dr. Park, I need you to time anesthesia depth so we can briefly reduce heart rate during extraction. 30 seconds of bradycardia, controlled and reversible. Sarah's instructions came rapid but clear. Dr. Chen, position the bypass equipment on standby. If we get uncontrolled bleeding, we'll need circulatory support within seconds. Marcus Chen moved with practiced efficiency, his Navy medical background recognizing protocols most civilian surgeons never learned. Bypass ready. Standing by. Dr. Hartman stood near the back of the OR, arms crossed, watching Sarah work with an expression that cycled between professional skepticism and grudging fascination. He'd performed thousands of cardiac surgeries, but he'd never seen anyone approach shrapnel extraction like this, treating the heart as a dynamic system to work with rather than an obstacle to overcome. First fragment is superficial, embedded in epicardial tissue. Sarah used microforceps to grip the metal shard with movements so delicate they seemed almost meditative. Extracting now. The first piece came free cleanly. A fragment no larger than a grain of rice, but positioned where it could have caused fatal arrhythmia if left in place. Fragment secured, moving to the primary ordnance. Sarah's focus never wavered as she worked deeper into the surgical field. This one's more complex. It's wedged between cardiac muscle fibers, creating a natural plug that's preventing hemorrhage. When I remove it, we'll have approximately 8 seconds before bleeding becomes critical. 8 seconds? One of the junior residents, Amanda Rodriguez, couldn't hide the fear in her voice. That's not enough time to... It's enough if everyone does their job perfectly. Sarah's tone carried absolute certainty. Suture ready? 4 neuroproline with cardiovascular needle. Hemostatic agents positioned for immediate application. Dr. Park, prepare for rapid volume replacement if needed. The OR fell silent except for monitors measuring heartbeats that Sarah was about to manipulate with surgical precision earned under fire. Reducing heart rate now. Dr. Park adjusted medications with practiced timing. You have your 30-second window starting. Now. Sarah's hands moved with fluid economy. No wasted motion, No hesitation. Just pure surgical mastery honed in places where second chances didn't exist. She gripped the primary shrapnel fragment, feeling the resistance of tissue that had grown around the embedded metal, extracting. One smooth motion, timed perfectly between heartbeats. The fragment came free, jagged metal that had been millimeters from ending patient X's life. Blood welled immediately into the surgical field. Suture. Sarah's voice never rose despite the emergency. Her hands moved faster than conscious thought, placing stitches with precision that seemed impossible given the speed. Hemostatic agent. More exposure. Keep that retractor steady. The surgical team responded like an orchestra following a conductor who knew the music by heart. 8 seconds that felt like 8 hours. Sutures placed with accuracy that defied the chaos of blood obscuring the field. Hemostatic agents applied exactly where tissue needed support. And then, impossibly, the bleeding stopped. Patient X's vitals stabilized, blood pressure rising back to normal range. Cardiac output improving as the heart, freed from embedded ordnance, resumed function that trauma had been suppressing. The monitors showed numbers that made Dr. Park exhale relief. Blood pressure normalizing, cardiac rhythm stable. He's stabilizing. Sarah worked for another 2 hours, removing smaller fragments, repairing tissue damage, ensuring every closure was perfect. She narrated each step, transforming emergency surgery into a teaching moment that residents would remember for their entire careers. The key is understanding that battlefield injuries don't follow textbook presentations. Sarah's hands continued their methodical work while she spoke. You adapt technique to the injury, not force the injury to fit technique. That's how you save lives when protocols say it's impossible. Dr. Hartman watched from his position near the wall, and something shifted in his expression. Not quite acceptance, but recognition that he was witnessing surgical mastery that exceeded his own, and that this suspended resident had just performed a procedure he couldn't have accomplished. When Sarah finally placed the last suture and stepped back from the table, the OR erupted in applause. Residents cheering, nurses smiling with relief. Even the circulating staff who'd seen countless surgeries recognized they'd witnessed something extraordinary. But Sarah remained focused, checking patient X's vitals one final time, ensuring every monitor showed stability before allowing herself to acknowledge success. In the observation deck, Lieutenant Commander Riker stood with his SEAL team, watching one of their own breathing steadily, because a combat medic turned surgeon had refused to accept that survival odds were too low. And in the corner of the OR, Dr. Gregory Hartman slowly removed his surgical mask, staring at Sarah Mitchell with the dawning realization that arrogance had nearly cost him everything, including a patient who lived only because he'd been forced to surrender authority to someone whose skills he'd dismissed. The hospital conference room felt too small for the weight of truth it was about to hold. Patient X had been transferred to ICU, stable and recovering under armed guard. The Code Black lockdown remained in effect, but the immediate crisis had passed. Now came the reckoning. Dr. Richard Moss sat at the head of the conference table, flanked by hospital administrators who'd spent the past 6 hours navigating military jurisdiction they didn't understand. Dr. Hartman occupied a chair near the back, still in surgical scrubs, expression carefully neutral. Sarah stood near the door, uncertain why she'd been summoned to what felt like a tribunal. Lieutenant Commander Jake Riker entered carrying a tablet and an authority that made everyone straighten instinctively. Ladies and gentlemen, I believe clarification is required regarding Dr. Sarah Mitchell's qualifications. Riker's voice carried the formal tone of official briefings. He activated the conference room display, and Sarah's military service record filled the screen. Lieutenant Sarah Mitchell, United States Navy. Military occupational specialty, Special Warfare Combat Medic. 2 operational tours, embedded with SEAL Team 3, Afghanistan, and Iraq theaters. The room went absolutely silent. Riker continued, his presentation methodical and devastating. Decorations include Silver Star with Valor for extraordinary heroism under fire, Bronze Star with Combat V device, Combat Medical Badge, Navy and Marine Corps Achievement Medal, Purple Heart. Dr. Moss stared at the screen, then at Sarah, shock evident in every line of his face. Lieutenant, you're military? Former military, Sarah corrected quietly. I left active duty 3 years ago to pursue civilian residency. The Silver Star. Riker pulled up after-action reports that made several administrators visibly pale. Awarded for actions during a 12-hour firefight at Forward Operating Base Echo, Kabul Province, 2018. 8 SEAL operators sustained catastrophic injuries from an IED strike. Lieutenant Mitchell performed battlefield surgery on all 8, while the position was under sustained enemy attack. He displayed combat footage. Grainy, chaotic, showing a field surgical tent with mortar impacts visible in the background. Sarah remembered every second of that night. Remembered the smell of burning fuel mixing with blood. Remembered making decisions that would haunt her, or save her depending on outcomes measured in heartbeats. Most notably, Riker's voice dropped with something between respect and awe. Lieutenant Mitchell extracted cardiac shrapnel from Petty Officer First Class David Chen while under direct enemy fire, using minimal equipment and no backup. Chen survived with full cardiac function. That procedure, performed in a collapsing tent with inadequate lighting and incoming mortars, is identical to the surgery she just completed on patient X. The silence that followed felt like held breath. Dr. Moss turned to Sarah, and his expression mixed shame with disbelief. Why didn't you include any of this in your residency application? This level of experience, these qualifications, because I wanted to be evaluated as a physician, not as a veteran. Sarah's response came simple and honest. I wanted my medicine to speak for itself. I didn't want preferential treatment or assumptions about what I could handle based on where I'd served. I just wanted to learn to save lives without carrying a weapon. She paused, meeting Hartman's eyes across the room. I came to civilian medicine believing it would be cleaner somehow, less complicated, but I learned that egos kill just as efficiently as bullets, and politics destroy careers as thoroughly as combat. Hartman flinched at the words, but didn't look away. Riker closed his presentation. Patient X is alive because Lieutenant Mitchell, Dr. Mitchell, performed a procedure that civilian protocols declared impossible. She saved one of my operators using skills earned in places most people can't imagine, applying techniques that make traditional surgeons uncomfortable, but produce results that can't be argued with. He turned to Dr. Moss. Her suspension was unjust. Her warnings about patient complications were accurate. And her dismissal from surgery represents exactly the kind of institutional arrogance that costs lives. Doctor. Hartman stood slowly, all eyes turning toward him. For a long moment, he said nothing, just stared at Sarah with an expression that had transformed from defensive anger to something more complicated. Recognition mixed with regret. I nearly killed patient X, he said quietly. By refusing to listen to someone whose experience far exceeded my own. By dismissing expertise I didn't recognize because it came from sources I didn't respect. His voice cracked slightly. Dr. Mitchell, I owe you an apology that words can't adequately express. Sarah nodded once. Acceptance without absolution. Because some mistakes required more than apologies to repair. And in that moment, the suspended resident became the surgeon whose skills could no longer be denied, whose past could no longer be hidden, and whose future would finally be determined by the lives she saved, rather than the protocols she challenged. 6 months after the surgery that changed everything, Sarah Mitchell stood at the podium of Naval Medical Center's main auditorium, looking out at 200 faces, surgeons, residents, combat medics, military physicians from installations across the country. The suspension had been formally rescinded within hours of patient X's successful surgery. Dr. Moss had issued a public apology that acknowledged institutional failure to recognize expertise that didn't fit traditional hierarchies. Dr. Hartman had been placed on administrative review, though Sarah suspected the real punishment was having to confront his own arrogance in ways that couldn't be ignored. Lieutenant Commander Riker had offered her a position that would have restored her military rank, given her command of surgical teams, put her back in the world she'd left behind. The offer was generous, respectful, everything she might have wanted 3 years ago. She'd declined. I left the military to practice medicine without carrying a weapon, she'd told Riker. But I can consult, train your medics, help bridge combat medicine and civilian care without going back to war. The compromise had led to this moment, the inaugural session of the Tactical Medicine Integration Program, teaching civilian surgeons techniques earned under fire. The procedure I'm about to demonstrate saved patient X's life 6 months ago. Sarah activated the surgical simulation display. Posterior cardiac shrapnel extraction using modified thoracotomy approach. The technique was developed in Afghanistan, refined through 6 successful battlefield applications, and translated to civilian operating rooms where protocols said it was impossible. She walked them through every step, not hiding the combat origins, not pretending the techniques came from traditional medical training. The audience listened with rapt attention, some skeptical, some fascinated, all recognizing they were learning approaches most textbooks ignored. In the third row, Dr. Gregory Hartman sat taking notes with the careful attention of someone rebuilding expertise from humility. When Sarah paused for questions, he raised his hand. "Dr. Hartman." Sarah acknowledged him with professional courtesy that had replaced earlier anger. "I want to say publicly what I should have said 6 months ago." Hartman stood, facing both Sarah and the assembled audience. "I dismissed Dr. Mitchell because I couldn't imagine a resident knowing more than me. I let ego override patient care and nearly cost a man his life because I refused to recognize expertise that made me uncomfortable." He paused, voice carrying genuine regret. Dr. Mitchell was right about every concern she raised. Right about the patient who coded. Right about the approach patient X required. Right in ways that should have made me listen instead of react defensively. He met her eyes. "I'm attending this seminar to learn from someone whose skills exceed my own, and I encourage every surgeon here to do the same." The auditorium erupted in applause, recognition of both Hartman's humility and Sarah's vindication. After the seminar concluded, Sarah gathered her materials while attendees filed out, many stopping to ask questions or request consultation on difficult cases. She was fielding a question about modified suturing techniques when someone cleared their throat behind her. Patient X stood there, no longer sedated and dying, but recovered, fit, wearing civilian clothes that couldn't quite hide his military bearing. His real name was still classified, but his gratitude wasn't. "Doc," he extended his hand, "wanted to thank you properly. You saved my life twice. Once in Kabul back in 2018, once here 6 months ago. Pretty sure that makes you my guardian angel." Sarah shook his hand, feeling the strength of someone who'd come back from injuries that should have been fatal. "Just doing my job. Both times. Your job saved 8 operators in Afghanistan and 1 here." He smiled. "That's 9 families who still have someone to come home to. 9 lives that continue because you refuse to accept that some injuries were too severe to survive." He saluted, sharp, precise, the gesture of respect that transcended rank, and walked away, leaving Sarah standing in an auditorium that had emptied except for students lingering to ask more questions, to learn more techniques, to understand how combat medicine could save civilian lives. Dr. Marcus Chen approached from where he'd been observing. "You know, when you first arrived at this hospital, I thought you were just another resident trying to survive surgical training. Turns out you were a decorated combat veteran teaching us what medicine looks like when protocols aren't enough." Sarah packed the last of her materials, looking around the auditorium that had become her new battlefield, one where victories measured in lives saved and knowledge shared instead of enemies defeated. "I'm exactly where I'm supposed to be," she said quietly, not hiding from who I was, finally becoming who I was always meant to be. And as she walked toward the exit, past photographs of surgeons who'd shaped military medicine, she knew that recognition had finally come, not despite her past, but because of everything that past had taught her about saving lives when everyone else said it was impossible.